good morning, everybody. Thank you for joining us for EST. A very unusual way of getting together, unfortunately, with the pandemic. Every year we've managed to get together and have a great meeting, and I hope this will be the same. I'd like to thank Shak, Qureshi, Iqbal Malik, and Mark Turner for all the effort they've put in to get the program together, and we will have a great program, which Margot will go through in a minute. I'd like to first of all thank the team in the UK. Could I have the first slide, please? So none of this would be possible without the UK team, who work effortlessly over the last year to try and keep everything going. We have Margot, Sanam, Keith, Laura, Katie, Luke, who've all worked tremendously hard over the last year to keep things moving and make sure that we get our kit out there. This is an educational grant from Occlutech for EST. And this is something that we've continued to support over the years. I'd like to now hand over to Margot.
Hi, welcome to the 4th Annual Emerging Structural Technologies Conference. It's been an absolute pleasure to organise this conference. I just want to remind you that the conference is recorded and will be available on demand on the website. So to kickstart the meeting, I will introduce you to our EST directors that need no introduction. We've got Shakeel Qureshi from the Evelyn Children's Hospital, Iqbal Malik from the Imperial College Healthcare NHS Trust, and Mark Turner from the University Hospitals Bristol. The agenda will be divided into 3 sessions. Session 1, ASD closure from 10:05 to 11:05. Session 2, which will be TAVIs from 11:05 to 12:10, and session 3, PVR closure and AFR from 12:10 till 1400 hours. Just reminding you again that this is an educational event that is supported by Occlutech. We've also been accredited 8 CPD points by the Royal College of Physicians, and we will send you your individual certificates via emails on Monday. We will also be sending you a short survey after the meeting to help us improve for future and for feedback. We would be so grateful if you could fill that in. It will take you 2 minutes. Otherwise, have a great meeting and don't hesitate to contact me if you have any questions. You should all have my email. Otherwise, it's on the EST website. Thank you.
Good morning. I'd like to add my personal welcome to everybody attending this important educational event. In these strange times, hopefully at some stage this year, we will return to physically present conferences. But nevertheless, we've got to put up with this as long as we can. And I'm going to pass this on to Neil now. To get us going. Neil?
Thanks, Shakeel. I'm very much looking forward to this session on ASDs. And first of all, I'd like to introduce Saleha Kabir, who's going to talk about the echo assessment of ASDs. Saleha.
Okay. So I hope everyone can see my screen, but thanks for asking me to talk about the echo assessment of ASDs this morning. I'll try to keep time and I'll be whizzing through quite quickly. So what do we need to know outside of the cath lab? So before we get going, we need to know our patient. We need to know the size of the patient so we can choose the appropriate probe from the get-go. And it's important to review any previous imaging that may exist. Forewarned is forearmed after all, and it's better to go in with as much information as we have as possible. However, once the probe is down, it's kind of all up to you. So use a systematic approach to assess the whole heart, all the structures, and then in terms of the defect, go through the angle systematically from 0 degrees to 150. And don't forget the pulmonary veins. It may have been recorded somewhere that there are normal drainage and things like that, but actually it's up to you to make sure that you can make sure you see all of the pulmonary veins before you get going. Look out for any unexpected contraindications, and with the older population, do think of function, think diastology and raised PA pressures. Look for absent and floppy rims. Try to estimate how much of the circumference of the defect they make up, because if it's too much, it may be contraindicative to closing with a device. And make sure you look for any prominent or mobile eustachian valves or Chiari nets that might get in the way as you're going along. So these are kind of like your main views when you're looking for ASDs within the heart. At 0 degrees, it's really important to do a superior to inferior sweep. Not only will it allow you to check for any fenestrations that may be present, but it will also give you an opportunity to rule out the presence of a sinus venosus defect. At 90 degrees, make sure you roll anteriorly from the aorta, posteriorly to the pulmonary veins, so you get the width of the septum as well. But these are your kind of take-home views that you need to be doing over and over again throughout the procedure. So on these 2 3D rendered images, what you can see is a nice garden variety secundum ASD slap bang in the middle of the septum. And it's all about location and making sure that the team has a common vernacular in the room. So we can talk about the location of ASDs in those terms. So something nestled between the aorta and the SVC would be an anterosuperior defect, etc., etc. But have a good conversation with your team so you all know what you're talking about when you describe defects. So let's move on to measurements. What measurements are we looking for? Well, obviously the defect, we need to know how big it is. We measure this on color and on 2D, and we measure firm edge to firm edge. Somewhere between the dropout that you see on 2D and the blooming artifact that you get on color will be the number that you're looking for. The rims, I'll just go through those in a moment. So there are several rims that we need to pay attention to. And the total septal length. So this is sometimes more important in pediatrics, where a large defect that requires a big device may not be able to be accommodated within the space. So that's something that might be a little bit more pertinent to smaller patients. But if you can't see the total length, which you can't sometimes see in adults, don't make it up. It's better just to say it's at least something rather than guesstimating what you think it might be. So measuring up, we see our pulmonary venous rim best at 0 degrees and 150, likewise the AV valve rim. We see our posterior rim in the short axis views and our infraposterior rim a little bit further around at 70 degrees. We have our aortic rim in any of the short axis views that show the aorta, and then we have our inferior and superior rims in the bicaval view. We can also measure these on 3D zoom, which is a particular favorite of mine. So this ASD is the same one that I showed you on the render earlier. And although it's just a live 3D zoom image, you can actually see the margins of the defect quite well. And you can see that you'd be able to measure, if you wished, the space around the defect. But more commonly, I guess we use it to measure the size of the defect, as you can see in the 2 examples here. So as I mentioned previously, Chiari and eustachian valves can be a bit of a bugbear in the cath lab, and they can form the variety of this long and aneurysmal-like strand, which is particularly troublesome because you may end up tracking it across to the left heart, which is not where you really want to see it on the end of a wire or on the end of a catheter. So you must be aware. Or however, they may take the appearance of a prominent pseudoseptum and sometimes can be mistaken for the septum itself, and then you get erroneous measurements. However, when you do a bicaval transgastric view and get the IVC flow in, which is sometimes hard to get mid-esophageal, you can see where that structure is in relation to the IVC flow and understand whether that's a septum or whether it's a eustachian valve. So we advance our guide wire from the femoral vein through the IVC, LA pulmonary vein usually. And it's often quite useful to watch this in progress and make sure that it ends up in a pulmonary vein and not within the appendage. When you have multiple defects, it's sometimes difficult to actually tell which defect a particular wire is going through. And in which case, sometimes 3D imaging helps because you can visualize quite nicely exactly where the wires and catheters are going. So balloon assessment. While balloons are not always used routinely, they are more frequently used with multiple defects, with aneurysmal septums and PFOs. If there's any uncertainty with the measurements that you're getting or any inability to see rims, then actually it's quite useful to use a balloon. We use a stop flow technique. So as soon as the flow is stopped through the ASD, you stop stretching so that you don't tear the tissue or overstretch the defect. So here we can see in this panel, the balloon passing over in towards the left heart. You want to position it so you've got an equal amount over the left and right sides of the septum, so you can see a nice clear waist in the middle to measure. And in this panel, you can see that same image on 3D imaging, where you can see a nice tight waist, which can be measured thus. So let's take a breath. What do we know so far? We know what our cardiac function is. We know how many defects they are. We know where they are. We know what size they are and what the rims may be. And we also know, by virtue of the balloon or otherwise, how the surrounding tissue behaves. So we have a good idea of what device we might need at this point. So let's talk about the device delivery. The delivery sheath is passed across the ASD and positioned into the left upper pulmonary vein as such, and not into the appendage, as we've mentioned. We can watch the device pass through to the mouth of the sheath, like so. And then the LA disc is unsheathed clear of the pulmonary veins. It's brought into position up against the septum. And once it's in position, the RA disc is then unsheathed, like so. On occasion, and especially in fluoro-free situations, we might deploy the device directly from the RA, whereby a sort of a bulb of the LA disc is released and pushed across the defect and released in that respect. You have to be aware of approaching the septum into acute angle, because then it might just fall through, as we have here. You want to try to release your RA disc clear of any, floppy tissue or eustachian valves that might be present. This isn't always possible, but it's good to be able to try to see if you can try to avoid them. And what you don't want to do is unsheath the device too prematurely within the pulmonary vein, like there. So our pre-release checklist, what do? We go systematically through the angles. As I mentioned, this is what we do over and over again. Check for good tissue capture of the rims, look for residual leaks around the discs. This is important. Ensure there are no obstructions to surrounding structures, and look for any imposition on tissue structures, because this increases the danger of erosion. So in these two panels, on the top panel, you can see the device that's seated with the discs splayed nicely around the aorta. However, in the bottom panel, what you have is a slightly oversized device, which may not be suitable for keeping in place, as it's kind of impinging on the aorta and actually sort of deforming it a little bit. In this panel here, we've got good IVC and SVC rim capture. You've got tissue within the discs nicely. But in the bottom panel, what you have is an oversized device, which is kind of impinging on the SVC flow, and you've got this sort of alias flow coming through the SVC. Remember that bulky devices are likely to flatten once they warm up within the heart. The profile will get smaller. Look around for the position of the device in relation to the posterior rim, often seen best at sort of 150. Make sure that you're clear of your pulmonary veins, that they can still flow in a very laminar way. Remember that flow through the device is acceptable, because this will obviously reduce with time. It's flow around the discs that might suggest an inappropriate size of device that you're looking for. And then check to see what the device looks like in relation to the mitral valve. It can sometimes ride low, but what you don't want to have is a change in function, any new regurgitation, or any sort of imposition that you may think might cause an erosion or a problem in the future. We can also assess the rims on 3D, and I mean, this is not necessary, but it is quite cool. You can see the device on NPR here with the tissue captured all the way around. And you can see the tissue nestled within the discs quite neatly there on the 3D rendered image. So we assessed stability. This is best viewed from a short axis view, involves a hefty push and pull on the delivery systems to separate the discs. If the device hopefully remains in place, then you reassess through all the angles as previous. It's good to see the releasing of the device on echo, because once you release the torque, the device can change position quite dramatically, as you can see in that clip there. And even in the bottom clips there, you can see that the difference between the appearance of the device while it's attached to the delivery system and once it's been released. Again, reassess the device through all the angles and document the presence of any residual defects, especially in the presence of fenestrated septa. Assess your cardiac function and exclude the presence of a pericardial function. So device closure of ASDs is part of routine now. However, it's important to know the heart, know the defect, be alert for any complications or contraindications, understand the procedure and what's going to happen, and repeat the thorough checks that you do throughout the procedure. Be present and be vocal. They want to hear what you're saying, otherwise there's no point in you being there. And yet still, with all of the meticulous things that you might do, you might find that your device ends up somewhere you don't want it to be, and then you can spend an awful lot of time trying to fish it out, which is not fun. But that's not the image I want to leave you with. I want to leave you with what we hope to achieve when we embark on these procedures, which is a well-seated device within the septum. And just I want to thank the team for everything that they do when I'm in the lab. Thanks.
So, thank you very much indeed. Well done. Some excellent pieces of advice there. Just for the audience, very important, we want to make this interactive, and so please ask your questions. I know there are a couple of questions on the screen somewhere. Iqbal or anybody who?
Yeah, so from the audience, could I ask on their behalf, are we now doing ASD closure without pre-screening TOE, or is that something that the panel's already always done and never had a screening TOE in advance?
I think we generally, with the pediatrics specifically, definitely have a screening echo wherever possible. I think it's rare that we end up doing a sort of a query proceed, if you like. Even with the adult team, I think they mostly get a TOE beforehand.
So what about in the land of COVID? Because TOE is an aerosol generating procedure. Have you modified?
We haven't done that many elective ASDs during COVID, to be perfectly honest with you. So I don't know, I think maybe Shaq might be in a better position to ask that.
Yeah, so the ASDs are not urgent. And if they are, then we would be in a position to do TOE and proceed rather than screen them and send them back, because that's not practical. There are a couple of questions there. One of them is, Sal, can you do ASD closure without TOE? That's one of the questions.
I'm sure that is something that's done routinely in certain places. I have no doubt. I think it's quite useful though, because you can definitely reduce the amount of radiation you're using. And you know, we've often in the Evelina, well, I say often, we have done fluoro-free procedures. So likewise, we can do it without the X-rays as well. So I'm sure yes is the answer to that question.
Yeah, I think it's a wider question. I think.
Shakeel, can I ask,
yeah.
do you have much experience with ice with regards to septal closure in this situation to avoid a TOE altogether?
When ICE originally came in, I used it and it was useful, but the problem is the cost. And at that time, there was lack of clarity about the number of times you could use the ICE probe, and therefore it was quite costly. And so we really stayed with transesophageal echo. But there are countries around the world where ASDs are closed entirely with transthoracic echocardiogram. And in fact, Zhangbing Pan in China does all the interventions, ASDs, VSDs, PDAs, with just transthoracic echoes and without fluoroscopy. So it is done and it can be done. You really need to have good echo windows.
Yeah, I think that, sorry to interrupt. I think
yeah,
your patient population and your body habitus, and there's a lot of things that might make that difficult, I think, in the UK, shall we say.
And then another question there. Sorry, Alain, go ahead.
Oh, yes, I just wanted to mention an additional interesting option, which is done which I have done in France, is to do this procedure under local anesthesia with the neonatal transesophageal probe, because it is possible to do that. It is very well tolerated in adult patients, and it provides, of course, you have a problem of contact with the probe, but it provides reasonably accurate images. So it allows permanent monitoring as opposed to the transthoracic echo, and it has been done now in many French centers, not yet published, but this is, I think, an interesting option, especially in centers like our centers, when you are doing both children and adults, and when you have the neonatal probe. So I would like to try that very much, but for now I have had a bit of administrative issues.
Yeah. Sal, another question is balloon sizing or not? You want to address that?
Oh, well, as you know, Shaq, in our department, we've got, 6 of one and half a dozen of the other. So I think that it definitely has a role, and it's definitely useful, in certain situations if you're not sure of how the tissue is going to behave, or if you've got multiple holes and stuff. So I think that, I would not dismiss it out of hat. I definitely think it's got an important role. And, it takes away, at least in the operator's mind, if that's what you're used to doing, it'll take away any uncertainty. So then, in fact, it's quite useful. Okay.
And then one more question, 30 seconds answer, and I might pick on somebody else. Which patients should get a pre-ASD closure MRI scan?
Let me take that.
Yeah, go on, Iqbal.
And say it should be probably all of them if you've got the time to actually do it. I think predicting you found every single pulmonary vein on a TOE, well, you look for 4. What if there's a 5th? You might miss it. And also it gives you a shunt calculation and RV function. So the question is, why wouldn't you?
Yeah, I mean, in children, we don't tend to because the issues are, firstly, imaging is easier and the answers are usually clear. Adults, I agree. All right, thank you very much, Sal. I think we're just overrunning a little bit, so in interest of time, Neil.
Yeah, so next up is Sophia Yong. So you're going to talk about ASD's indications for closure. Thank you.
Right. First of all, thank you for inviting me to talk at this conference. I would like to thank all of the organizers. So today, Sal's just shown everyone quite beautiful pictures and brilliant pictures of how to assess ASDs and sort of how to assess it on echocardiogram. I'm going to talk a bit about why we do it and what are the indications before we go ahead and close an ASD. So no disclosures or conflicts of interest. So just a little slide on the types of ASDs that we have. Incidence of it 0.5 to 1.6 per 1,000 live births. For the main purpose of this series, we are talking about the secondum ASDs, which makes up about 75 to 80% of all ASDs. And you've got the primum ASDs that make up about 15%, and then go on to the sinus venosus ASDs, and then the very, very rare coronary sinus ASDs. So why do we close these ASDs? So in the pediatric age group, you get patients who come who are largely asymptomatic, and some of them, in a small proportion of them, may have failure to thrive, poor development, and of course, recurrent respiratory infections in the pediatric age group. And then you get the other extreme where they present in their adult life, usually in the around the 30s and 40s, where they have exercise intolerance, atrial arrhythmias, mainly atrial fibrillation, flutter, and potential pulmonary hypertension. So ASD device closures, we have had quite a long history of them ever since the first ever device by King and Mills in 1975, some 40 odd years. It is now the first line treatment of secondum ASDs in most centers. Up to date with a variety of different devices, which we'll see throughout the day today, and also variety of different types of techniques that we can use to try and help us to close ASD device closures. So then why do we do it? So this is just a small picture of the first initial device and see how far we've actually progressed over the years. Indications for ASD device closures, same as surgical closures, left to right shunt. You get to see right heart enlargement, as you saw on the last talk, where you see quite a lot of dilated right hearts. QBQS of more than 1.5 to 1, providing that the PVR is less than 8 Wood units, which is what we tend to follow. Cyanosis, you can get them with intermittent right to left shunt across an atrial septal defect. And of course, potential paradoxical embolism that can lead to strokes. That is also one of the indications for closing these ASDs. Now, these are just some guidelines that we can see from the ESC guidelines that was recently published, which generally all of us do follow. Just one more slide on kind of the traditional criteria on ASD device closures, which I'll just go through. So traditionally, we've talked about only secondum ASDs that we close with the device that are accepted within the interventional community. More and more now, we are seeing people challenging this sort of technique, and sinus venosus ASDs closures by transcatheter method have been published recently, and as well as case reports of closing coronary sinus ASD can also be done in certain circumstances. Of course, then we talk about assessing an ASD with sufficient rims of more than 5 millimeter, which was the traditional teaching. Nowadays, again, as well as device to weight ratio of less than 1.5. People are challenging this as well. There are some published cases up to even a device weight ratio of above 3, and diameter less than 40 millimeters. But that is not technically the case, as most defects tend to be oval rather than round. So you could potentially close larger defects and nowadays as well. So the rims, the device weight ratio and diameter, all of these rules have been broken since we started closing ASDs 40 years ago. These are some of them. And finally, PVR of less than 8 is kind of the set criteria that we follow, or less than 2/3 systemic. But again, we know as well, you could potentially precondition these patients with some pulmonary antihypertensives and potential some medications before going ahead to try and partially close them with the various devices that we have out there right now. I think that's it. Thank you very much.
Thank you, Sophia. Excellent and very quick, sticking to time. In fact, taking less than that. Just for the attendees, very important, we want to make this interactive, as I said earlier on. So please ask any questions and we will try and answer them as best as we can. We've got various people, especially Iqbal, keeping an eye on the questions from the attendees. Now,
Shakeel, can I kick off with a question? Just to, so especially in adult medicine, patients sometimes are found incidentally to have a small ASD. So outside of the traditional indications for closure, for example, if they've had an echo for another reason, and they do not fit any of the criteria for closure, how hard do you look for example, evidence of a systemic embolus to close? And if that's negative, how do you manage these patients? Because some of them, of course, don't do very well with knowing they have an ASD in their heart that may be related to a stroke in the future, but that we're not going to close.
Okay, Sophia.
Sorry, yeah, okay. So I think with this kind of patients, where there is no traditional indications for closure, a conversation with the patient is probably the best sort of way to go forward. If the defect itself looks indeed transcatheter closable, I think I would go ahead. I would offer a patient the treatment, and then if patients accept the risk and potential benefits in the future, because you don't know when they will develop the atrial arrhythmias in the future, whenever that could potentially happen. So I would offer the treatment and go ahead with the procedure.
So if a patient has a run of AF, they have an echo, they're found to have a small ASD, small shunt, normal RV, normal MRI, you would consider closing that on the basis of a single run of AF if they were very keen and understood the risk of that procedure?
I think the first thing to do in this kind of instance is probably to get an EP opinion, official EP opinion, to see what whether the AF needs anything doing, because what you don't want to do is to go and close the defect and then it turns out that the patient might need further procedure like pulmonary vein isolation after that. So yeah, I think it's worth considering, especially if the EP opinion is also of the same lines. Yeah.
Shaq, can I ask a question, please? I guess it's a comment, really, Sophia, and a challenge, really. I mean, you mentioned the hardy perennial issue of children and device size in terms of millimeters per kilo. Yep. And it's something that always really bothers me, because I can remember when I was a trainee and a young consultant going to meetings where people sort of used to trot out this 2 to 3 millimeters per kilo. And if I think that if I just say, your average 3.5-year-old weighing 15 kilos by your criteria should easily take a 30 device or maybe even a 45 device. And that's just not true. And it's not safe either. So I think you have to be really, really careful with that. And I just, I think it's something that people throw out a lot. It's appeared in guidelines in the past. And of course, there've been papers written, but I just wanted to kind of point that out, really, and ask for your comments on that.
Oh yeah, yes, definitely. I think it's good to see what other people or what the rest of the world are doing, and within the interventional community, and to see what sort of barriers that have been kind of trying to you try to achieve. But I'm definitely very cautious with that. And one of the things that I do look at in the pediatric age group is definitely just to make sure that the left atrium is definitely going to be able to accommodate that left atrial disc. I think that's the main thing. And also a potential for device erosion. So those kind of deficient aortic rims, I would be very, very cautious about, going more than that, going more than a ratio of more than 1.5, 1.8. I know people have said that that's not that's not the rule to follow, but I tend to kind of take it case by case and not be very cautious about oversizing, definitely.
I know other people won't necessarily agree, but the point I'm making is it's not an arms race, particularly in very small growing children.
Definitely not, no.
Part of the problem, just to wrap things up a bit, part of the problem, John, is also the fact that if you're closing an ASD, very rarely would you close it in a baby less than a year. And if the baby's about, I don't know, 6 to 7 kilos or 5 kilos, and you put a 10 device or 12, 15 device, it will be accommodated. And the ratio is obviously going to be approaching 2 to 1, if not more. But you can't apply that device to weight ratio as the child gets bigger and into teenage years. That's the main message, isn't it, John?
Correct.
Yeah, I think so. Yeah, I agree, Shaq.
Okay. All right, good. Thank you. And again, the audience, there are 1 or 2 questions which we will answer probably after another one of these talks. Neil, let's keep moving then.
Great, thank you, Shaq. So Alain Fraisse is going to next speak about ASDs that should not be closed percutaneously. Thank you.
Alain, you're muted.
Can you hear me? Okay, great. I think you can hear me. So, thank you for giving me this opportunity. I'm going to straight move to, if I can make my slides. Well, unfortunately, I cannot move my slides. Well, can I have the... Yeah, I cannot move my slides.
Dr. Fraisse, I can share your slides if you want.
All right, go ahead, please.
Yeah, just...
Can you directly move to the third slide?
Yeah, just I need to give me 1 minute.
Yeah, this is unfortunate because we tried. Yes. We tried that. It was working, but now it's not anymore working. Sorry about that. All right, move to third slide. And then this is summarizing what we have already seen, the different rims. I like to keep the difference between the posterior and the posterior inferior rim because it is really fundamental to make the distinction about what can be closed and what cannot be closed next. And this is a very important study from Gianfranco because the question is what is the percentage of ASDs that can be closed in the general population? And Gianfranco Butera published this very important study in 15 years ago, and the number is 80%, 80, and they excluded extreme cases. Next slide. Next slide, please. By including those extreme cases with deficient posterior rim, in our experience, 10 years ago, we were reaching a proportion of 94% of ASDs that can be closed. So I'm going to show a few examples that may challenge what has been said. Next slide. So one of the questions is really the use of modified implantation method. And you can see this defect with very deficient and floppy rim, a small left atrium. And so I have introduced the Lucky Luke maneuver. So Lucky Luke is a famous Belgian comics that is characteristic is that he's shooting faster than its own shadow. So then you can imagine the modified implantation maneuver. Next slide. And this is basically illustrated by the shadow is a prolapse of the device. So you need to be faster. You need to kink the device in the posterior part, and you need to be faster to implant the device faster than the prolapse. And this is the advantage of the Occlutech is that the softness of the left atrial disc that really allows this maneuver, which is also possible with the implant there, but clearly easier with the Occlutech. And you can see that the device is perfectly well implanted. And there is, by the way, only one defect and not multiple. This is also what I call the octopus defect, because on some use you will see multiple defects, but this is just the rim of one single defect. Next slide. Now let's move to the adult. Well, no, not to the adult yet. So, I mean, this has been addressed in the previous topic. How large is too large? And I agree with Shaq that you cannot think with this 1.5 ratio, because in a small child, you can easily do 2. but obviously in an adult who is weighing 80 kilo, you don't have a 80 millimeter device. So this ratio, I would say, is not relevant. And in small children, you can go clearly above 2, even if it's quite impressive. This patient has a very deficient posterior rim, small left atrium, and this patient was scheduled for surgery, but fortunately he had, or unfortunately, I don't know, he had a bronchiolitis, and the consultant moved, and I saw the patient in clinic. So I challenged the MDM. I told my colleagues that the parents would agree about that, and it is certainly not the first time I am doing that, because I clearly think that this type of defect can be caused. Next slide. And it's of course very impressive, because you see the device seems very oversized, and you even have a functional mitral regurgitation here, because I think it is important to make the distinction between functional. When you abruptly increase the shunt, you are likely to have a bit of functional mitral regurgitation that will disappear after a few months. And we published with a French group a series of 40 children to challenge a little bit this statement of 1.5. And especially in small children, you can very well go above 1.5, but I agree that after 20 kilo, this is becoming more complex. Next slide. So now let's move to the adult. And this is another adult with deficient posterior rim and small left atrium. And this patient was also scheduled for surgery and came after a second opinion. And you can see that the sizing of the defect is more than 4 centimeters with this non-compliant balloon, which I prefer to use with very big defect in adults. Next slide. And then the key issue to close this defect is really to open the device where there is more space towards the mitral valve. Of course, you pay attention on TOE that you don't traumatize the mitral valve. And usually after that, this is easy to close. In this particular next, you can show the motion of the, if you click, you can show the motion of the device. Next slide. Yeah, you can see that. Next one. And the same day, interestingly, it was the first day in my life, I used 2 40 millimeter device during the same day. And this is just to show the limit of the measure with 2-dimensional echo. This defect is measured at 1.8 centimeter. We can see with color that it is much bigger in this 18 years old. And this 18 years old, next slide, was more challenging. It was more than 4 centimeter. And then in this type of situation, you can use a Mullins sheet that will help you to open the device towards the mitral valve. This can be also successful. Next slide. So this is a discrepancy between next one, between the what you measure in transthoracic echo, and in this sense, I agree about the need for optimal imaging, especially MRI, in some of these patients. Next one, next slide. Yeah, and this is a patient I've done 1 week ago, basically, and I just want to state that the orientation also plays a role. This patient has deficient posterior and anterior rim, and you can see that on the left screen there is a deficient posterior, and on the right screen here, you can see when you follow the inferior vena cava that you have a nice IVC rim, which is the most important. The defect is measured at 19 millimeter on TOE, and at 26 millimeter, 26.8 on transthoracic. Next slide. And then sizing balloon is 24, but 24 in fact is too small. And in this particular case, what is important is that in fact between those 2 rims on the non-compliant balloon, you have a lot of oblique distance, and then you can have a slight underestimation because this posterior rim is much deeper than this anterior rim. And then with the non-compliant or semi-compliant balloon, you can measure this more accurately at 26 millimeter, and this patient will end up with a 27. Next slide. Next slide, yeah. And yes, this is, by the way, another fast deployment maneuver, which is necessary, and the defect, the device is not oversized. Next slide. So just to show you what I mean, in that this patient has two defects, one anterior, one posterior. And look, the two defects are at a 90, the two devices are at a 90-degree angle. They are perpendicular to each other. So this illustrates that when you measure a defect with anterior rim deficiency and posterior rim deficiency with a non-compliant balloon, you can slightly underestimate the distance because you measure in 2 dimensions something with the oblique distance. So this may also explain the difficulties to close those large posterior defect and anterior defect as well. Next slide. So you can see on the transthoracic echo, you see there is a 90-degree angulation between the two devices. Next slide. And my last example, or one of my last example, is how to make the distinction between posterior and posterior inferior rim deficiency. Posterior inferior rim deficiency, you can't close, or you close with high risk. Posterior rim deficiency, you can close. These two defects, they look similar. So one of these two defects is not suitable, and you see in this subcostal view, you don't see the IVC. And when you can follow the IVC, then you can see your posterior inferior rim deficiency. So which of the defect can be closed? There is one of them that can be closed, whether it is this one, this one. Next slide. And this one, you can see there is a very good inferior rim. When you follow the inferior vena cava, you can close it. Whereas this one, you see the inferior vena cava, you see no rim. So this one, you can't close it, or you will close it with a high risk. Next slide. And this matched my experience where, but just another example, just to say that when you have superior rim deficiency, you can close it as well. You see there is not too much rim towards the IVC. Sometimes you have a bit of velocity when you put the device, but this can be perfectly closed. Next slide. Well, next slide as well, because this is much again the same feature, deficient superior, posterior, and posterior rim. Next slide, next slide. Next one, please. And this is my last slide. Next one. Yeah, so my experience with posterior inferior rim deficiency match all the complications I have had. I have never had any embolization out of these patients. I have had 4 embolizations with 18 cases, 4 failure, and importantly, I could succeed, but sometimes you can have a residual shunt with cyanosis. So you can transform a left to right shunt into a right to left shunt. And this is illustrated in this patient who developed cyanosis during exercise. You can see we operated this patient. Half of the device is traveling the inferior vena cava, so it is redirecting the blood flow towards the LA. And this patient, of course, shouldn't be closed. Next one. And this is difficulties in adults is you cannot really follow, you cannot have a good subcostal view. Next slide. So this is just to show, can you move this is my last slide.
Need to finish.
So, yeah, so this device is going to be embolized. Half an hour to retrieve it with a double sheet technique. Next slide, this is my last slide. Yeah, so in conclusion, yeah, so that's fine. I'm done. So just to insist on patient selection, taking account that there is no really, I would say, absolute rule about what you can close, what you cannot close, except the inferior posterior rim towards the IVC, simply because even if you can position a device, and you can almost always position the device, it will slide towards the inferior vena cava. Thank you.
Okay, Alain, thank you very much indeed. That was excellent with technical problems. We're overrunning a little bit. One question from the audience is balloon occlusion and pressure measurements. Are there any particular levels where you say don't close this defect?
So with the balloon sizing, I don't really consider when I cannot size defects. So first, when I have a small left atrium, I don't use a compliant balloon, because by using the compliant balloon, especially in small children, you completely occlude the left atrium. So sometimes it is useful to use a semi-compliant balloon, and then usually when I have a defect that looks to be very large, I almost always try the 40 millimeter device, and I have also asked, I think it would be useful sometimes to have a slightly larger device than that. And then most of the time, you can position the device. The big question is whether the device will stay. And the answer to this question is whether or not there is a posterior inferior rim deficiency. And in this stance, I think the TOE is a bit limited because sometimes you have difficulties to make this, to distinguish the posterior from the posterior inferior rim. Then MRI, 3D echo, all these techniques can be useful to select those patients.
And last question before we move on, because we're a bit behind again. And it's important to give the right message to the attendees, because not everybody is going to be as skilled as you. But there's a small list of types of ASDs which really the average or moderately good interventionist should not be closing. If you had to give a list of 2 or 3, what would it be in clear terms? Not the ones that you can do, I think I want to emphasize that, but the ones that people should not be attempting.
Well, I try to make everyone, I think in this situation, discussion with other interventionists, like not only me, you, John, are relevant. If you feel, if you have any doubt, I think in these cases, I would just insist on the need to discuss simply these cases. But because other than that, my only rule is really posterior inferior rim deficiency. And the last thing is also how to retrieve a device. I didn't have the time to go through that with my last slide, but with the Occlutech, it is a little bit more complex than with the Amplatzer. And I think the double long sheet technique, which has been also described by our colleague in Greater Mount Street, is very interesting. Maybe we can go through that in another session.
Okay, very short answer for this one. If you have a 2 millimeter AV valve rim, so near the mitral valve, would you close it?
Well, it's often not 2 millimeter all the way. So yes, I use arrays to attempt that because I think there is almost always a margin of security. I never had a patient who had to be operated from his mitral valve after closing this type of defect. And then you can only see when you position the device whether or not the mitral valve can be compromised.
Yeah, okay. I've come across around the world patients where the device is protruding onto the mitral valve leaflet and we've taken the device out. Okay, thank you very much, Alain. That was very stimulating. So Neil, let's keep moving now.
Great, thanks. Next is Salim Jivanji, who's going to talk us through his best difficult case of ASD closure. Thank you, Salim. I think you might be muted.
Salim, unmute.
Yeah, just 1 second. Seem to be going into the middle of the slide for some reason. 1 second, I'll just try again.
You're going to miss your flight of this, right?
Salim, would you like me to share your slides?
I'll try one more time.
Okay, no problem.
Okay. So thank you for the invite. I have no disclosures. I'll talk about a case which we did when I started off at Liverpool, and it was quite an interesting one. So a 40-year-old male with paroxysmal AF and had some exercise intolerance, went to his GP, got worked up for a murmur and found on an echo to have a dilated right ventricle with an atrial septal defect. So transthoracic echocardiogram, which we discussed in the JCC, showed that there was a left to right shunt. On the left panel, on the left image, you can see that there is what looks like a reasonably large defect and then suggestion that it might be fenestrated or maybe even 2 defects, SVC coming in. And then on the right panel, you can see that the right ventricle is quite significantly dilated with tricuspid regurgitation. And then there is a left to right shunt as well on that picture. So came in for the procedure, had a TOE, So forgive me, my images are nowhere as nice as Sal's. So, but anyway, this is what we had. So at 0 degrees on the left panel, you can see a left to right shunt with a good size AV valve rim. And then on the right one, rotating it to about 30 degrees and just bringing the probe a little bit higher, that same defect shows an absent aortic valve rim. So a reasonably large defect. So as is the case, I spend a considerable amount of time having a look. So depending on what your center setup is, whether you have somebody who's going to help you with the TOE or whether you want to do it yourself, sort of noted there was a second defect as well in the middle, in addition to the one which was near the SVC aorta. So we already knew that there's going to be 2 defects over here, and we had a good assessment of that as well. So in terms of measurements, the bigger defect measured about 19 millimeters on color, and the smaller one measured about 9-10 millimeters on color again. So in this image, if I can show you my cursor, so the defect was here, the bigger one, which is near the aorta. So the aortic rim was deficient, and then the second one was over here. So the question amongst us was, how do we close it? Should we use 1 device or 2? I think it's important for you as a team to know what equipment you have available and what devices are there. So when we did this procedure, we hadn't yet had Occlutech devices, so we were limited to Amplats at the time. And the choice is whether you use a self-centering device, which is large enough. In this case, the largest one available is 35 millimeters and wouldn't have covered the bigger defect. So we decided to use 2 devices. So I won't spend too much time on this one because I think Sal has covered this really well, but just briefly, so at 0 degrees, this is the image I showed you. When you turn up to 30, you come up and see the aortic rim and the defect at that point. And then at bicable view, which is about 90 to about 110, you see the SVC and then the second defect. And this paper has been published by Bushra Rana, who's one of the panelists in 2018. It's quite interesting if you want to have a read. So we decided to balloon size. So we put 2 axes, a left and a right femoral vein, crossed both the defects on TOE, had a proper look that we were going to the separate devices, separate defects, and then we put it in just 1 balloon. So the option is whether you put 2 balloons or 1. But in the case of this patient, I was pretty confident where the defects were. So we just used 1 24 millimeter Amplat sizing balloon just to get a confirmation. And then confirmed it with a balloon, on fluoroscopy and on TOE in terms of what the measurements were. So 10 millimeters for the smaller one, and the superior one was about 20 millimeters. So we decided to go for a 12 and a 22 millimeter device. So what we did was we put in the first device, which was a smaller one, and then decided to put the second one over it. So there are so many different ways of doing it. You can leave a balloon in and put in the first device to see what the interaction is, or you can simultaneously deploy the left disc on both the device and then bring the right and then the right. But in this case, I think because it spent such a considerable amount of time assessing on TO, we're pretty confident that this would be the best option. And you can see already on this image that it sat really nicely. So then echo assessment again. So on the left-hand panel, this was the first deployment of the smaller device on the left panel. It didn't sit really well, so we redeployed it. And then you can see on the right-hand panel, on the 30-degree angle, the relationship at this angle is superior. Well, on this picture is up and down in terms of how the devices were sitting. So it's really important to just really understand the anatomy. And as Sal was saying, and the communication with the person who's doing the TOE is very, very important so that you understand the rims and the position of where the defect is and that you're not missing out on anything. So there's a bit of through device leak, but we were not too concerned about that. So just another picture showing that to make you understand that the devices were sitting well. And then released the first device and then had another really good look and made sure that that was sitting well. So on the right-hand TOE panel, you can see the rim coming into the device, and sitting quite well and securely. And then release the second one, and both the devices sat really well with very minimal sort of regurgitation. So send the patient home on aspirin and clopidogrel, and maybe we can discuss that in terms of who goes on what. But we felt that, you know, two reasonably large devices on one patient, we should send on 2 antiplatelet agents. And he came back and everything was fine, and he's got a very, you know, it looks well, there's no residual defect, no issues there. And just for peace of mind, we did a chest x-ray to make sure that there was no issues from that point of view. So the number of publications on it in terms of multiple defects and how you should approach them, I think as long as you've got some system and a plan in place, it should be all right. But from the learning points for this case, and I think it's really important, just prepare for the case. I always review the transthoracic echo before the patient comes in. And one of the questions which was asked was, does everyone have a TOE? So in our center, we get TOE done in their local centers for adults, but not for pediatric. But we will list to proceed to avoid a second anesthetic. And also just match the size of the right ventricle and symptoms to the defect. If you feel that the defect's too small and maybe you're missing something. Know your equipment, take time to assess your ASD with a TOE very well so that you understand what's going to happen. And then consider balloon sizing to get a better feel, ECG after. And if you're not sure, make sure you ask for help with your colleagues to understand what you're planning to do. That's it, thank you.
Right, thank you very much indeed, Salim. That helped to make up a little bit of time. There's 1 or 2 questions. One is, did your patient have an EP opinion, either at the JCC or beforehand?
Yes, so he was seen. So if they have any evidence of atrial fibrillation or something, we will often ask the EP. So we have an EP consultant which sits in the ACHD MDT, and they were happy for us to proceed. And if they needed to go in, they would go in at a later stage. So this is a one-off episode which he didn't have any further ones, and he wasn't on any treatment for it. And so yeah, so we do have an EP opinion pretty much for any patient that come with an arrhythmia.
Yep. Okay. Good. Iqbal, did you have a question?
Yeah, I've got a sort of a comment and a question. I think the ECG obviously is quite important because I know at least of one case where complete heart block occurred with a well-sat device. So related to that question is, how long do you keep people in hospital? Because that does vary a lot. Is it a day case procedure, or are you watching them for 48 hours for something? And actually, I noticed that whenever that case was done, there was no 3D echo. Gimmick or essential, Salim?
So if you have somebody who can do fantastic images like Sal, then it's really, really useful, I think, in terms of seeing the defect position. And I think in this particular case, it would have been very, very useful. But you need the right equipment as well. So in Alderhay or in Liverpool Heart and Chest, it's a relatively new ACHD service as well. So we don't really have a full setup of equipment in terms of doing 3D imaging and all that. And we also don't have all the staff. So as long as you can do a very good 2D TOE, we're more than happy. And I personally understand 2D TOE much better than 3D as well. So I don't think it's essential. Our patients also, I think one of the questions which I wanted to address was whether everyone has a TOE before and then as a separate procedure, or they, and have a separate procedure for the closure. We'll often be referred with a transthoracic, even in adults. And if we feel it looks possible, then we will proceed with the procedure with TOE plus proceed. But, it's very rare that we can't close it based on what we see.
Neil, Shak, can I just make a comment to add to what Salim's just said? Coming back to the issue of ICE, which was referred to earlier on in the in this session, and the other reason that I absolutely prefer TOE over ICE every single time is that you get an extra pair of eyes looking at the atrial septum. And if you build a good team and you have really, really good images, that's worth more than its weight in gold. And for me, that's the biggest argument for TOE, frankly.
Yeah. And what about, there was a question about doing multiple ASDs in one procedure or separate procedures. Salim, any thoughts on that?
So you mean assessment of multiple ASDs before?
Yeah, if you know them beforehand, whether you do one procedure to close one defect and then come back another time for a second procedure for the other defects.
I mean, I think if you're able to close all the defects, in one procedure, then I can't see why you'd want to do them separately, unless there is going to be an issue in any way, and I can't really think of any. I think this is probably the fifth or sixth one that I have done where you have requiring two devices, and we just sort of proceed and go ahead with them. So. Yeah. And there was a question as well, which is.
Can I elaborate on my question, because it was my question about doing them twice? It's
Oh yeah, go ahead, Mark.
So I used to do this 2 devices at the same time, but now that there are a number of reasons why I think I've moved towards more often doing them separately, and we just bring the patient to the cath lab and do the TOE, so you often don't know until the day exactly what you're doing. But I think if you have one device that's at the top near the aorta, and you stick another rigid device underneath it, then I worry that makes you more likely to get erosion, because you've got a rigid thing inferiorly. Maybe it's less of an issue with Occlutech because of the erosion risk probably being less. And I think when you have the 2 defects, often the atrial septum, as we all know, isn't a straight structure. So they often interact with each other in a really strange way, because one bit's on one part of the curve of the septum and another's on another part. And I think if you've got 2 separate defects, I'm tending to now put the superior one in first, let it all heal in and come back. And I'm actually then sometimes coming back with ice, because I usually do the more inferior one second, and we've already fully evaluated the septum. And I think you then do 2 low-risk procedures rather than one more complex high-risk procedure. And I think things like erosion, things like embolization are likely to be less. And having done them both ways, I've moved away from doing the fancy, clever procedures like you've just done there, which is all very impressive.
Well, I've gone the opposite, I'm afraid, Mark, just to be different. I started off doing, when we had multiple ASDs, I would do 2 separate procedures, wait 6 months or even longer. And then I found that it's much easier, less fiddly, doing 2 devices at the same time. So I've actually gone opposite to you. But one question that I was going to ask then, which was asked by attendees, was in that sort of situation, and probably generally, which device is then better? And you partly alluded to it, the Amplatzer or the Occlutech or any of the other devices.
So I think in this particular case, an Occlutech device would have been really useful because of the softness and also the way that it sort of interacts with the cable. But I suppose you use what you have, and at that time we only had the Amplatz device. But if the Occlutech one was available, I think I would have probably found the procedure a bit easier. But just asking Mark's question in terms of doing it as a separate procedure, I wanted to ask him in terms of interaction with the devices. You'll still have interaction with the devices when you do it as 2 separate procedures. So how does that change in terms of you wanting to do it as 2 separate procedures, apart from the risk of potential embolization?
Well, I think the 2 points were if you have a rigid. So I think a long time ago, I've just forgotten his name now, but one of our colleagues who looked into erosions a lot. One of the issues for one of the safety things for erosions, if you have a very floppy inferior septum, and in contrast, if you stick a rigid device inferiorly, especially if you oversize it a little bit, then I think it can push the device up towards the roof of the atrium and the aorta. But I've no evidence for that, but it's some comments that have been made from people who've studied erosions. And I think once one device is endothelialized in place, so if you wait 3 or 6 months, then the first device can't embolize, and then you can evaluate what hole you've got left better. And I've sometimes put a Gore device. If it's a very little device, I've put a Gore device inferiorly. You can kind of choose then to close the second hole with whatever you want to close it with when you see what the remainder is, and there's no chance of embolizing the first device because it's already healed in.
Just briefly, Mark, just briefly, there is one of the arguments for a second procedure is you put in a big device in the big hole and then wait for 6 months or a year, and it may be that the other hole has been compressed to such a degree that it's only a couple of millimeters or less, and therefore there's no hemodynamic reason for actually chasing that. Any thoughts on that?
Well, that's another reason, I think, but another potential reason. And sometimes, as you say, the residual defect is so covered by a slightly oversized device that you don't have to go back. And that's, I didn't mention that as one of the reasons, but that is another potential reason.
That's a much better reason for me.
Okay, I think we better wrap up.
Very quickly.
Yeah.
Yeah, Neil, go ahead. Sorry.
I was just going to say, Alain, I know you've got a comment, but I think we're now running 5 minutes over, and I think we're just very keen to keep going with the program as we've got lots of interesting talks coming up. So yeah. I think if you all agree, I'd just like to thank all the speakers for wonderful talks and an excellent discussion. And I think we're moving on to the next session on TAVI. I think Mark and Shaka, you're moderating that one.
Yeah.